Good day, my name is Imelda Williams. This presentation is feedback on the chest practice bank that I gave you. I trust that you've worked through the preliminary image evaluation form. Please keep this at hand as this is a formative feedback so that you can mark your preliminary image evaluation as we go along for each of the cases. Okay, for the first case we have a patient with shortness of breath. And if we look on the software, on our APA view, when we zoom in, we can see that the patient has had a sternotomy. But we can also see that we're losing the left border, so the lower zone, the heart border has been obscured. And this is indicative of consolidation of the left lower zone. On the lateral view as well, we can see with the posterior area of near the spine that there is the area of consolidation. So on our PAE form, so the case is abnormal. So the lungs are abnormal because when we look at the left lung, we can see that we've lost lung volume on the left side. The cardiac and mediastinum has been affected. As you can see that there is the mediastinum is enlarged and the cardiothoracic ratio will be enlarged, and then also the diaphragm, because we've lost the left lower lobe, and that is indicative of left heart border that's obscured. So the PAE form is comment then is that there is extensive left lower zone consolidation, and looking at the clinical history, that's indicative of pneumonia, and then also to mention that the left heart border is obscured. For case 2, we have a patient with acute onset of dyspnea and query pneumothorax. So when we look at case 2, the first thing that you would probably notice is that the trachea has been displaced to the right side. When we look at the right side, there are lung markings. However, when we scroll through the left side, we can see that there are no obvious lung markings in most of the lung. There's just a little bit of the lung that's collapsed, so most of the lung has collapsed. So there's a large left-sided tension pneumothorax, and we can see that because the heart has also been pushed over to the other side. So there's mediastinal shift, which indicates then that we have a tension pneumothorax. So on our form then, it's abnormal. The airways is abnormal because the trachea has been displaced. The lung is abnormal. We've only got a very small part of a collapsed lung. Mediastinum is abnormal. There's mediastinal shift. And the diaphragm, edges and pleura is abnormal. So the overall PAE is that there's a large left-sided tension pneumothorax with a collapsed left lung, as well as obvious mediastinal shift. So with case 3, we have a patient with a history of colon cancer and receiving chemotherapy, so a chest X-ray was requested on this case. So for this case, quite obvious, you can see large dense nodules of various sizes, and it's dispersed through both of the lungs, and that is very typical then of bilateral metastases. There's no evidence of any pleural effusion or anything else. So in our PAE form, it's abnormal and the lungs are abnormal, and the overall PAE is in that there's bilateral multiple lung metastases. For case 4, we have a term baby who's on CPAP and the oxygen sats is 90%. There's continuous positive airway pressure, and this is a form of positive airway pressure ventilation. So for this case then, if we look in the area of the mediastinum, the first thing that you will notice is that we have this continuous diaphragm sign, and this is where the diaphragm in between the right and the left has an outline of gas. If you follow the gas pattern, you can see that it is around the mediastinum. So this is pneumomediastinum. Then this also outlines, of course, the thymus. And then with the left side, there's a left hemothorax, left hemithorax, and this may represent a small left-sided pneumothorax. There's nothing that we can see on the right side. So in this case, then it's abnormal. The cardiac and mediastinum is abnormal, and then the diaphragm and pleura is abnormal. So the overall PAE is that there's gas that outlines the thymus, and there's a continuous diaphragm sign, and this is in keeping with pneumomediastinum. There's a lucency of the left hemithorax that may represent an associated small left-sided pneumothorax, but on the right side, no pneumothorax is observed. Moving on to case 5. This is a patient with acute onset of dyspnea, and there's decreased lung sounds on the left side. So for this case then, clearly you can see on the left side, got a very small lung volume left, and then there's a large white dense area which indicates that this is a pleural effusion. We can see with the lung on the left side that it has a typical meniscus sign. If you also look very carefully on the right side, there's slight blunting of the right costophrenic angle, which indicates there's also a small pleural effusion on the right side. So for this case then, it's abnormal, the lungs are abnormal, cardiac and mediastinum and the diaphragm as well as the edges of the pleura is abnormal. So the overall PAE is that there's a large left-sided pleural effusion, and there's blunting of the right costophrenic angle with a possible small pleural effusion. So case 6 is a patient who was referred for a routine PA of the chest as a pre-op. So the first thing that you will notice is that the marker is correct on the left side. When you look at the apex of the heart, it's towards the right and not the left. And the important thing is when we look under the diaphragm, we can see that there is the stomach contents is there. So this is dextrocardia with situs inversus. So it's abnormal. And the cardiac and mediastinum is abnormal as well as the soft tissue because the stomach is now also on the right side. So the overall PAE is dextrocardia with situs inversus. Case 7 was a mobile chest X-ray that was requested, and that was post a nasogastric tube insertion. So if we follow the nasogastric tube, we can see that it is not going into the left side where the stomach is. However, this has been misplaced, and it's been misplaced into the right thorax, and this has resulted in a pneumothorax. So if you look very carefully, you will see that there's an area where there's no lung markings, and also the area around the nasogastric tube now has consolidation of the right lower lobe, and that's probably because the patient has been fed before the check X-ray was requested. So in this case, it's abnormal. The airways and lungs are abnormal. The airways and lungs is abnormal, and the breathing and lungs also, because you can see on the left side that there is a loss of lung volume, and then the edges we've got a pneumothorax, so the pleura has been affected. So the overall PIE is there's a misplaced nasogastric tube which resulted in a right pneumothorax and consolidation of the right lower lobe. For case 8, we have pediatric patient who has right-sided crackles, cough and fever, but there's some improvement with Ventolin. So we can see that this is the area that's affected is in the right upper lobe. We have this ill-defined opacity, and this probably represents segmental atelectasis and secondary to mucus plugging. So on a PIE form, it's abnormal. The lungs are abnormal, nothing else is abnormal apart from that. And then the overall PIE then is there's a right upper lobe ill-defined opacity, which probably represents segmental atelectasis, secondary to mucus plugging. For case 9, we have a patient with fever, cough, and query chest infection. So if we zoom in, we can see the left side is fairly clear. There's nothing sinister going on. On the right side, though, we can see that the right upper lobe has got cavitation, so there's some bacterial infection, but there's also a secondary area, and there's lower lobe consolidation, which is in keeping with segmental pneumonia. So abnormal again, so the lungs is the only that's affected. So the overall PIE is that there's bacterial infection in the right upper lobe. You can see this cavitation present. In the cavitation you can see the black air within the dense consolidation. And then also in the lower lobe there's consolidation, which is in keeping with segmental pneumonia. For case 10, we have a patient who was hit by a tree branch on the left side of the chest. So if we zoom into this case, first thing that we can see in the soft tissue next to on the left side, there's abnormal air tracking, and that's due to surgical emphysema. We can also notice that there is a pneumothorax on the left side, and this of course becomes more obvious with an expiratory view where you've got the loss of lung markings. It does appear as if there could be a fracture of the anterior rib, of the fourth anterior rib. So in this case, the lungs are abnormal, the bones of the skeleton is also abnormal, and the diaphragm is abnormal. And as well as the soft tissue. So the overall PIE is that there's a large left-sided pneumothorax. There's also left-sided surgical emphysema, and then there's a query rib fractures in this case. Case 11 is a young child with fever and cough and reduced lung sounds on the right side. So the first thing that you will notice here that we have loss of the right heart border, and as you know that the right middle lobe is flush against the right heart border, and that indicates that there is a opacification of the right middle lobe, and linking it with the history, this indicates then that there is a right middle lobe pneumonia. So in this case we have, it's abnormal, the breathing and lungs are abnormal, and it also affects the cardiac and mediastinum. So overall we have right middle lobe pneumonia. With case 12, the patient was admitted with acute chest pain. It also had abdominal pain +++ and distension. So for case 12, if you look very carefully, on the left side we have the stomach bubble, but we can see on the right side that there's the diaphragm and then there's abnormal air under the diaphragm. So this is pneumoperitoneum. So it's abnormal. The lungs are abnormal, and then the diaphragm and soft tissue is abnormal, and the overall PIE is a pneumoperitoneum. For case 13, we have a patient who's complaining of shortness of breath and regurgitation, and the request was to exclude any pathology. So on this case, we can see that there is definitely cardiomegaly. But if we look very carefully just behind the heart within the mediastinum, we have an air fluid level, gas fluid level, which should never be there, and that indicates that there is hiatus hernia of the stomach contents. So for this case then, it's abnormal. Cardiac and mediastinum is abnormal, and I should actually have ticked off that the soft tissue is also abnormal. So the overall PIE is that there is a hiatus hernia, and there's also cardiomegaly. Case 14, patient was referred with for chest X-ray with symptoms of fever and right chest pain. So if we look at the PA view, we can see that there is an area of consolidation, but within that we have this black gas, and that indicates that there is an infection, so it's an abscess. But if we look very carefully, there is a foreign body lying within the right middle lobe area. On the lateral view, similarly, we can see the area of consolidation with the abscess, and then there is lying within that there is a foreign body, and this foreign body was identified as a needle. So it's abnormal. The lungs are abnormal, and then so it's an inhaled foreign body which is noted in the right middle lobe, which has caused a surrounding abscess. So the final case is that of a patient who's a smoker and now has a chronic cough. So with this case, if we look very carefully through the case, we can see it's very good inspiration. There is no signs of any pleural effusion or pneumothorax or any areas of consolidation. So this is a normal case. So back to our form now. The only thing you need to tick off is that the case is normal under general opinion, and then to write in your overall PIE that the case is normal. So this is the end of the chest cases. If you have any queries, please feel free to contact me. Thank you.